Do you guys know most of your members that are part of this group?
No, so it's all virtual. And there's also another person named Mike. Is that a doctor?
Yes, he is one of the other doctors here.
Okay, so I'll let him in as well. And we're live, so feel free to take it away whenever you're ready.
Okay, welcome everyone, and welcome to another session with Pre-Dental Universe. My name is Tiffany, one of the pre-dental students monitoring today's session, along with Sherry. We have an exciting presentation today with Dr. Deliz-Guzman. And on that note, feel free to take it away whenever you're ready, Doctor.
Thank you very much, Sherry and Tiffany. And thank you everybody for joining. My name is Dr. Ronaldo Deliz. I'm from a group practice in Raleigh, North Carolina called Tar Heel Periodontics and Implant Dentistry. In our practice, we are all periodontists. There's 4 of us in our group. As you can see in the first slide that's showing it, there's Dr. Justin Valentine on your left, Mike Stella right after him, myself in the middle, and then Dr. Michael Kretschmer at the end. So a little bit about myself. I was born here in North Carolina at Fort Bragg, so I am an Army brat, but I was raised in Puerto Rico. My family is from there. For those that don't know, Puerto Rico is in the Caribbean, part of the United States. A little bit about how I ended up as a periodontist. I did my education in Puerto Rico, University College in my hometown in Madrid, West Puerto Rico. I then did dental school in San Juan, Puerto Rico from 2009 to 2013. After that, I did do a GPR in New York, and then decided to go into private practice in my hometown in Puerto Rico as well. I did that for about 2 years, and then I decided that I still wanted to keep learning. So I ended up doing periodontics at St. Louis University in Missouri, which periodontics is a 3-year program. So I graduated in 2019, and in 2009, at the end of that program, the guys at Tar Heel decided that they would love to have me over. So I moved down to Raleigh, North Carolina, and I have been here ever since. So our group loves to do these types of presentations to either pre-dental, dental students, even dentists around our area. So this is an example of continuing education that we do complimentary all over the Triangle area. All these are virtual with the exception of our opioid courses and CPRs. So all the virtual ones, anybody that's attending today, you can easily log in and be a part of these presentations. And we do provide CE for those that are available, that can have them. So this is something that we love to provide to our community, and we like to give back in this way. So our practice, basically, we have 5 offices all around the Raleigh-Durham area. So we have one in North Raleigh, Wake Forest, Durham, Cary, and Garner. Basically encompass almost like in a star, the Raleigh area. And we are only one of the only periodontal practice that's open Fridays and some select Saturdays in this area as well. So a little bit of, so I like to talk to pre-dental students. This is, I think, the second time I've done it to this type of group. One thing is that when I was in university, we actually didn't have a pre-dental group. So how I ended up learning about what's available in the dental field was when I went into dental school. So it basically, you're basically a step back if you don't know what is available before you actually enter into this new profession. So I'm thankful you guys for letting me talk to you guys. And what I wanted to talk to you about is something to show you what a periodontist can do in one particular field, which is something that's coming up more and more because a lot of dentists, general dentists, periodontists, oral surgeons, everybody is placing implants. Endodontists as well have been placing implants. So that then gives us what happens when we have an implant that starts ailing or an implant that starts failing. So the presentation I wanted to give you guys, it just shows you what, as a periodontist, what we can do to either save these implants or, unfortunately, what happens when it can't be saved. So the presentation is pretty clinical in the sense that you will be seeing a lot of cases, but it should give you I hope it gives you a good feel of what a periodontist can do in this case. Just a small little glimpse of what a periodontist does in the field. So without further delay, we'll get started. So we are going to talk about peri-implantitis, how to diagnose it, treat it. So what is peri-implantitis? So we have peri-implant disease can be separated into two categories. Basically, we have peri-implant mucositis, and then we have peri-implantitis as well. So peri-implant mucositis is an inflammatory process affecting the tissue surrounding the implant without loss of the supporting peri-implant bone, so any bone that's around the implant. This occurs following accumulation of bacterial biofilms around the dental implant. Now, peri-implantitis is defined also as an inflammatory process affecting the tissue around the implant, but has resulted in loss of the supporting bone. So clinically, when we look at peri-implant mucositis, when we probe around the implant, we are usually getting greater than 4 millimeters. So just to give you a reference point, when we probe around a natural tooth or a healthy, sometimes healthy implant, we want a 1 to 3 millimeters probing. Now, implants can have a deeper probing, but then the next part of this slide is what is affected. If it's bleeding, there's suppuration, that means that we have some sort of inflammatory process going on around that implant. Now, if it's probing a 4 millimeter and it's not bleeding, there's no suppuration, it's still a healthy implant. Now, compare that to the peri-implant mucositis. We are getting deeper probings, deeper than 4 to 5. Now, there's also suppuration, there's also bleeding, but radiographically, we can then see that we've lost bone around that implant. So now, the prevalence of this disease in implants for peri-implant mucositis, which is more common, it's around 38%. Now, peri-implantitis is a little less, around 5% of implants placed, we get peri-implantitis. Now, these numbers, unfortunately, are going up because the number of implants being placed by everyone is actually increasing as well. So what can we do to prevent us from actually ending up having to treat implants? So one of the things that we look for to make sure that the implant is healthy is that the implant is immobile. We want to make sure that there's absence of any peri-implant radiolucency. We look for any vertical bone loss, making sure there's always going to be some bone loss around the implant, but we want to make sure it doesn't go more than 0.2 millimeters annually. So it's very important. Let's say you have a patient, they come in for their regular maintenance visits every 6 months, but you take an x-ray, let's say once a year of particular teeth. You want to make sure that you take a look at those implants at least annually, and have a baseline for them. That is the best way that we can maintain implants because we have an idea of what it looked like when it was healthy, and then suddenly if you take an x-ray and you see something different, you can easily catch it and we can prevent us from losing an implant or having to go into very big surgeries in order to save that implant. Other criteria that we use to make sure that our implants are healthy and stable is that they shouldn't be painful, shouldn't be any infection, neuropathies, or any paresthesia in the area. Now, as a whole, implants are very successful. Like, the implants have a success rate of 85% at the end of 5 years, and usually 80% at the end of 10 years. So we are expecting these implants to last until basically we want our patients to basically be buried with their implants. We don't want our patients to lose any implants. So there are a few risk factors associated with peri-implant disease. So patients that have a history of periodontitis, there's always an increased risk of these patients developing peri-implantitis as well. Poor oral hygiene as well. That's why if we have patients with implants, it's very important that they continue coming back to their regular checkups every 6 months. If it's a patient that had periodontitis, they're doing their perio maintenances every 3 months. And we have to keep them that way so that they don't lose these implants, because they are more susceptible to eventually getting peri-implantitis because they had periodontal disease. And just because they have periodontal disease doesn't mean that it disqualifies them from ever having implants. We can place implants on patients that have developed periodontal disease as long as they are stable. We can place implants later on for them. Uncontrolled diabetes is another risk factor that we look for in patients that we're placing implants, as well as smoking. The reason is we have delayed healing with each of these cases. So a few other key factors in preventing peri-implant disease. Here I want to show you the difference between a natural tooth and an implant. So with a natural tooth, we have these fibers all around the tooth, basically creating a periodontal ligament that acts as a shock absorber to the tooth. Now, when we look at the implant, we actually don't have that for this implant. So it's very important that when the implant is restored, that occlusion is taken a look at, because if we have constant force hitting on this implant, it's not going to respond the same way as a tooth does, just because there is no shock absorber for the implant as compared to a natural tooth. So that is well, I'll go into the type of failures that we see. One of the most common ones is restoratively, we have mechanical failures because of what has been placed crown-wise. So another important aspect is how we actually place the implant. So another situation, another type of failure that we could have is a technical failure. So it would be where we place the implant. If the implant is placed too far facially, we could potentially lose the buccal bone or facial bone in that area. And when that happens, as you can see in this slide, we eventually start to see through the mucosa a silvery area. That means the implant is being shown through the soft tissue. And if this happens to be a front tooth, whenever the patient smiles, they start seeing almost like a blackened, grayish, bluish hue onto the gingiva. And that's not very aesthetic. There's bone loss around that area. So it's also detrimental to the patient because the implant wasn't placed in the correct spot. So it's always important when we are planning that this can be prevented all the way through, even before we place the implant, by planning it with a 3D X-ray or a CBCT. So it has become more standard that all implants, we take a CBCT to make sure where exactly we're going to place that implant to be able to prevent these types of failures. Another situation is when we're placing more than one implant side by side. We want to make sure that there's enough space in between implant to implant. If there isn't, like I said, we get bone loss around an implant naturally. But if these implants are placed less than 3 millimeters apart, this bone loss can actually get much worse just because they're too close together. So, like I was saying, we have 3 different types of implant failures. We can have implant failures that are biological. That means the implant has not been restored yet. So this occurs very early on, basically less than 3 months after placement. It can even happen almost the next day to a week out. That means that the body just did not take the implant well. Sometimes we don't know exactly why the biological failures actually happen, but they happen quick, they happen decisive. So the patient usually comes in, hey, I got the implant 2 days ago. It's weird because it feels weird, it hurts. And when we look, there's inflammation, suppuration. Okay, he's not accepting the implant has to come out. And so we do take those implants out almost immediately. And we just got to try it again at another time. Now, the other potential failures that we can see are mechanical. These happen after the implant has been restored. Usually, we have crowns that just don't fit or are adequate for the type of implant that's there. Sometimes it's how the occlusal forces hit that implant that end up causing the failure. And you'll see a small example of that in a little bit. And then we have technical, like the ones I was just explaining a slide over. And here we can see how that is, because the implant was placed too far facially, we started to see that bone loss, and eventually we got a dehiscence or loss of that tissue in that area, and we could see the threads coming from that implant, which aesthetically is very displeasing. And so we'll go over a few of these cases and how we treat them. So here's the example of a mechanical implant failure. Here we have basically when the implant was placed. We got good bone all around. The helium abutment has been placed. It's been torque tested. Everything has passed with flying colors. Basically, the patient is going back to his general dentist to get it restored now. Problem was that when they were restored, the crown was way too big for the implant itself. And we started a few months down the line, we start getting bone loss around that implant on both sides. So mechanical failures, we do see that if the contour of the implant is not ideal or the size of that implant crown is also not ideal, it could cause occlusal forces to wreak havoc on the implant. And we can see this saucer-shaped bone loss around these implants because of how much force is being applied onto that implant. It basically creates almost like a rocking cradle effect. And that's why we start seeing this type of bone loss here. So how do we treat peri-implant disease? So there's 3 ways we could treat it. One would be actually fixing the bone or hard tissue around these implants. Second one would be to try to repair the soft tissue around these implants. And then our final option would be, if there is no other choice, but to actually explant the implant. And we'll go over a few cases so you can see exactly what all these procedures entail. So we're going to go over first the hard tissue. So here we have an example of an implant. Patient came into our office with almost 50% bone loss around this implant. And this is the final one. So I'll take you step by step of how we went from here to here. So first of all, when we see the patient, we want to make sure that the implant can be saved. So the first thing is to see if it's ideal to save it, or if it's better off to just take it out and start again. In this case, this implant is connected to another implant in a bridge form. So and the other implant is actually healthy. So we want to be able to save this implant, because if not, she's actually losing the span of 3 teeth. Now, it helped us that this implant was not mobile. We just had this bone loss around it, and that's what we decided to repair. So we start by flapping that tissue in order to have access to the entire osseous defect. Now, when we opened the flap, we saw that the reason for this bone loss was that when this bridge was cemented, dental cement actually seeped down through the sulcus and into the implant, causing all this destruction. So it's very important that when you guys get into dental school and you're placing, let's say, your first crown or your first implant, or restoring these, and if you're doing a cement retained crown, please I would make sure that you've cleaned all the cement around this area, because even a little bit of cement can wreak havoc on the implant. Now, in order to be able to fix or repair this area, we got to eliminate these local factors that have caused this damage. So we eliminate the dental cement. We then eliminate all this granulomatous tissue or bacterial tissue that has grown around the implant. We want to make sure that there's sound bone all over, and we disinfect the threads of the implant as best we can. As you can see here, there's no more granulomatous tissue. All we see is sound bone, which is what we want to see. At that point, we then place new bone in that area. We pack it in as tightly as possible. Now, if you remember from the previous slide, we've completely lost the facial bone. So in order to get this implant back to health, we have to repair and recreate this facial bone. And in order to do that, after we place the bone, we place a collagen membrane around it so that it actually packs in that bone very nicely and keeps it in place. Once we've placed the membrane, make sure it's stable and not moving, we actually suture the area and try to get primary closure around the entire area, making sure that everything is nice and tight, and we let it heal for a few months. So here we have our sequence of our sequence of radiographs. So we have our initial one, which was in January. We did the procedure also in January. Here we have the next month, 3 weeks out. We have very good bone around that area after we regenerated, and then 1 year later, we still have that bone. So that implant is now completely healthy, and the patient is still able to keep that bridge in that area. So the second way that we treat these types of cases is by repairing the soft tissue. So we're going to look back at that same case that we saw before, where we have that dehiscence on the facial aspect of number 9. So for this case also, we do have to flap that area to be able to expose that dehiscence and that bone loss. Now, compared to the other case, we don't have as much bone loss around this implant. All The only bone that we lost was actually the facial bone because of how it was placed to facially. So when we need to repair, so this gives us the opportunity to repair it with soft tissue. So in order to do this, we actually use tissue from the patient's own body. Basically, we do what's called a connective tissue graft. That tissue actually comes from the patient's palate. Now, there are other areas that we could take this tissue from, but in this case, we use her tissue from the palate, and that gives us this connective tissue. So we basically harvest the tissue from the palate and then transfer it to the facial aspect of that implant. Now, we do want to get a larger size than what the defect was, because it'll provide us with better blood supply in that area, and it'll allow this graft to actually survive in this area. You might be asking, why aren't we placing any bone then? Well, because this is tissue from the patient's own body, it'll create a new periosteum in that area and will actually be much more beneficial to the patient in this particular case. So after we've sutured the entire area, we let this heal for a few weeks. And here we have the sequence of events after healing. So here you have your initial presentation. We did the procedure. 3 weeks later, this is how the patient looks. 3 months later, and then a year later. So we got very good tissue around that implant. We have good keratinized, bulky, thick tissue that'll help that implant. It'll keep it clean. So it was a very successful procedure, and like I said, no bone was needed to be placed, but we covered that dehiscence and repaired that area by using tissue from the patient's own body, or soft tissue from the patient's own body. And here you have a closer look at how it ended up. So now, not all implants can be saved. And so when it comes to that, we do have to take those implants out. So what happens when we have a failed implant? Unfortunately, the amount of bone loss that we have, we get a reduced vertical and horizontal bone. So we're looking at that we're losing height and then we're losing width at the same time. We also get a reduction of the tissue quality. So the tissue around the implant that's failing is already inflamed. It's tissue that is most likely being removed. That means we're not getting that tissue. That tissue is not going to repair itself. But we're losing quality in that tissue, as well as the quantity as well. And then if that bone loss is left unchecked, it could eventually be detrimental to the adjacent teeth or adjacent implants if there's other implants. So it's very important that if that bone loss is starting to get out of control, that unfortunately we do have to take out these implants. And so in order to help us, we do have a specialized kit that helps us remove these implants. This is an implant removal kit from a company called Salvin. It comes with different trephine burrs that are of different sizes in order to completely fit over the implant. Now, these are designed this way so that we take as less bone as possible, but still are able to take out the tooth. So we want to preserve as much bone in that area. At the same time, we need to take out the implant as best we can. And so what this allows us to do is that it weakens the bone around the implant, or breaks its connection to the implant, to the bone, I mean. And then we actually use these other instruments to torque that implant out, or basically unscrew the implant. It makes for the best possible scenario in taking out these implants. This kit also gives us the opportunity, if, in case we have broken screws from crowns, we can actually remove those screws and be able to save an implant as well. But that's a completely different lecture. This kit gives us the opportunity to either take out an implant or save an implant, just depending on the case. So we're going to go through a few examples of cases that we've used this kit. So in our first case, we have this implant, very long implant, unnecessarily long implant, but it could have been placed that long because it's very likely that this implant was placed as an immediate implant. That means that they took out the tooth and placed the implant there the same day. Fortunately, this implant developed bone loss after some years, and when we flapped it, this is the amount of bone loss that we had. Unfortunately, the implant was mobile. There's no way to stabilize it, so we decided to remove that implant. So here we have how the area looks after the implant has been removed. Because of the amount of bone loss that was originally there, we have a very big dehiscence in the bone, as well as in the palatal aspect of the bone as well. So in order to be able to repair this area, as you saw in the previous examples of the hard tissue, how we repaired it, we are going to place bone. We take an x-ray just to make sure that there's nothing else in this area that needs to be removed. Here you have how we pack that bone into place. We will place a membrane, just as in the other example, to be able to restore that facial tissue. Not only that, but we do tuck that membrane through the back so that we can actually repair the palatal bone as well. So here you have how that area looks after the bone graft has been placed. And you can see that because we placed a membrane over it, we got that bone nicely packed in all the way to where that bone loss was. And that's exactly what we want to see. So after that, we suture everything into position. We want to make sure we get primary closure just so that we get the best healing possible. Here you have another example of everything sutured into place. So this patient heals very well. This is 3 months out. The earliest that we would place an implant, and this number changes depending on the implant, but a good number to be able to wait and let that bone mature is around 3 months. So at 3 months, we take a look at the area. We take a 3D x-ray to see how much bone we have now in this area. So if you remember how it looked clinically when we exposed and took out that implant, there was a massive hole in this area. Because we placed a membrane and the bone, we actually were able to basically thicken the bone in this area. And that provided us plenty of bone to be able to design a better angle for that implant, for their new implant. So another reason why this implant failed was because of the position it was placed in. So the original implant was placed along this axis. Now this is where the new implant will be. So initially it was coming out in this area. The new implant will come out in this area. And if you look, that is a better restorative position than where it was originally. So here we have the implant placed and with its healing abutment as well. And you can see on the x-ray how that implant looks very healthy at the moment. And here you have a comparison of the original implant and the new implant. It doesn't have to be as long as the other one. Actually, if you place an implant as long as the roots of the natural teeth, you'll have a very good and stable implant and good restoration for that implant as well. So our second case, now sometimes we get implants that automatically we know that we have to take out. In this case, we had a broken implant. So a patient came in and said, I think something's wrong with my implant. And when we took a look, yeah, it's missing the top part of it. Now, in these cases, we have to use that specialized kit because there is no bone loss around this implant. If he hadn't broken it off, this implant would have been just fine. But because it was broken off, there's no way to repair this implant. So we use those trephine burrs, which we would have the size of the implant, and then we would place the trephine burrs around it, and that trephine burr goes about 3/4 of the way down in order to break the seal or the seal that the bone creates around the implant. And then we slowly just back the implant out. That helps us preserve as much bone as possible around this area. And once the implant was removed, we just do what's called the site preservation and basically place bone in that area, let it heal. And this patient was pretty recent, so that's why there's still no implant in this area, is that hasn't healed quite soon enough for us to be able to place the implants. But he will have actually 2 implants in this area because this span was for about 2 teeth. So he now has enough bone that we can actually place 2 implants in this area. So here we have our final case. This implant was a little bit of a mechanical failure as well because of the type of crown that we had and the width of the implant itself. But when we saw this patient, we had more than 50% bone loss. And the implant was also slightly mobile as well. So there was no way that we could repair this area. We had lost the facial bone. We have lost the palatal bone as well. So there was also no access to be able to get to the screw of this implant. So our trephine burrs actually can't go through this crown. So the way that we took this implant out was that I cut off the wing, basically the sides of this implant, or basically all around it, because this is a 2D image. So we basically cut all around, basically making this into a stud, and then used the trephine burrs to be able to fit around it. And the implant came out. So because we lost the 2 walls around this implant, I had to place a membrane on the facial bone and then wrap it around the palatal bone once the bone had been packed in. And that's why it looks the way it does, so neatly packed into that area, is because that the membrane is actually pushing it down and compressing it, which is what we want to see in order to get very good bone in about 3 months. So this patient is well underway to having a new implant placed here in the next upcoming months. And then our last case. Now, this was an interesting case that came into our office. So these implants are actually all connected to this bridge. And so the implant that is doing the worst is actually the middle one. This is how they showed up into our practice. So yeah, there's something wrong in that area. So we decided the patient didn't want to lose her bridge, but she had a failing implant in the middle. So these implants were also came from Europe, or I think it was Turkey actually. And this is a company that is not placed here in the States, but it didn't matter in our case because the way that we were going to remove it, it wouldn't have mattered. So here we have the area when it has been flapped. And so we have this implant in the front, this implant in the back, and the one that is actually failing in the middle. So we decided to, in order for her to keep her bridge, we decided to section the implant from this portion down here and basically remove it from the bottom out. Here you have basically what we did. We basically use a burr to actually cut through the implant and remove it apically, or through the bottom. So once that's done, we actually removed all the granulomatous tissue, also any titanium flakes that are left behind. And we then regenerate with bone, place a membrane, and regenerate it as I've shown you previously through the hard tissue procedures that from the previous slides. And this patient did very well. Unfortunately, I forgot to get our x-rays post-op for this patient, but the patient is actually doing very well, and we managed to save both of these implants and her bridge at the same time. And that is it for me for this presentation. I will gladly answer any questions that anybody might have. So ask away.
Yes, thank you for that exciting and great presentation. It was very informative, and we appreciate you for taking the time to share your experience and the cases as well. With that said, we have a few questions in the chat, if that's all right.
Yeah, no problem.
Okay, cool. So the first question is, who would you recommend for patients to see if to ensure the best chance for implant placement? Since like many different specialties and like general dentists are now placing implants, like you said.
So everybody has different levels of training. So a specialist, either a periodontist, oral surgeon, we've been practicing placing implants for a very long time. Now, that being said, anybody can technically place an implant. You just have to be able to recognize that there are certain things that you need to be aware of around the area that you're placing the implant. You just can't maverick it in and like, okay, she has enough bone, boom, placed, bye. You have to take into account adjacent structures, where the patient is going to bite. All these, any dentist can actually take a look, see, and to be able to place the best implant possible. A lot of general dentists like straightforward cases, let's say anterior teeth and premolars. They usually send out to us when it's like a more complicated case. We're talking about molars, or if there's a sinus lift that needs to be done in order to place the implant, or if the patient just doesn't have enough bone and we need to augment the ridge. That's when they usually send to us to be able to augment the ridge and then place an implant later on. But to answer your question, technically anybody can place an implant as long as they take the proper precautions to assess the area in order to make sure that the patient doesn't end up having to have these treatments in the future. And if you don't want to place an implant, you can send it to your periodontist.
Thank you so much for the response, doctor. Another question we have is, when would you prefer a patient to get a bridge over an implant?
Usually, the patient is technically the one that ultimately decides what they want. If you have a single edentulous spot and you have two virgin teeth adjacent to it, I would highly recommend pushing the patient for an implant, just because you haven't prepped the teeth next to it yet. They have no restorations. They're virgin teeth. Why would you touch them? Meanwhile, you can easily place an implant, single unit, and you'll be able to restore that tooth into that position again. That is how I usually tell patients, like, they haven't touched your teeth next adjacent to this edentulous spot. Why would you want to do that now? Now, that being said, if we have the opposite, the teeth have been highly restored, both adjacent teeth, they have plenty of restorations already on them, there's an edentulous spot in between, then that would be a good case to be able to do a bridge on. But at the same time, a single unit in between that area works just as well, because basically the pros and cons are that if something were to happen to one of those abutment teeth, you'll end up losing the bridge. Now, if something happens to the implant, like in our cases, there's still a chance that we can actually restore it. Or if it needs to come out, we can just put another one in later on once we've repaired that tissue. But I hope that answered the question as best I could do.
Thank you so much.
Yes, thank you, Dr. Deliz. The next question is, can you describe your experience practicing dentistry in Puerto Rico and in the U.S.? Were there any significant differences between them?
Nope, no difference. Like I said, Puerto Rico is part of the United States, so I took the same boards that I did here for here. They're exactly the same. We have exactly the same insurance companies. Everything is the same. Maybe price-wise is the only thing that actually differs from the States to Puerto Rico. But it's exactly the same. We have a very good dental school down in Puerto Rico, and and very good dentists on the island as well. So it's a very good place. If anybody is thinking about applying to Puerto Rico, I would highly recommend it. Just make sure you have 2 years of college Spanish, because they won't let you in without it.
Well, thank you so much, Doctor, for your response. Another question we have is, how do you determine the length of the implants needed?
So that's a very good question. So like I said, we take a 3D x-ray before any implant case. That provides us the best opportunity to determine how long of an implant we can place, how diameter-wise the biggest implant that we can place as well in that area. So the 3D x-ray is what determines what type, what length of implant we place in each area. And we can digitally place the implants in the CBCT as well. And it allows us to move it exactly where we need to be and place it in the best restorative position possible, making life easier for the general dentist that had referred that patient over to us.
Thank you, Dr. Deliz. Another question is, what did you think about your dental school experience and your resident experience? Do you have any advice for students?
I love my dental school. My dental school was very clinical. Like Puerto Rico, at that time when I was in dental school, only accepted 40-some students a year. Everybody had a chair. We weren't fighting over who had a chair, who didn't, because the school just isn't big enough to have more than 60 students in clinic per year. So everybody had a chair. So everybody could see patients regularly every day. So as long as you made an adequate schedule, you could be seeing patients all the time and getting experience every day. It's just how well you made your schedule. So we had to call our own patients. I don't know if the programs here in the States did that as well, but we would have to call our patients, make sure that they were going to show up. Basically, we were our own secretary, assistant, and dentist, all in one, just to be able to get as many patients in as possible to get the most experience possible. So that would be the key, is to try as many procedures as possible, study them, and then try them when you're in dental school, just so that when you leave, you've dabbled in a little bit of everything before you graduate. Because once you get out in private practice, you are almost a newborn baby again. You won't know anything, so you would have to learn that again. And residency as well. Pick a program that is very clinical, very clinical. I would say, yeah, look for the hardest residency that you can find and do it, just because it'll give you an experience of having difficult patients and being aware of how to handle them. Like look for those GPRs that are hospital based, that are level ones, that you would have to be unfortunately on call 24 hours, just so you have that experience and you know how to handle emergency cases when they walk in. Yeah, that would be my advice. Like, don't be afraid to do procedures. Just go in, make an eyes, be prepared beforehand, and then you are able to do all those procedures before you graduate, or even in residency. I would recommend everybody to do a GPR. It'll just give you more experience for when you actually practice in the real world.
Thank you so much, Dr. Deliz. Another question we have, what do you like most about your work, and what do you find most challenging?
What I like about being a periodontist, I like the surgical aspect of it. That's mainly what drew me to periodontics, is that it was mainly surgical. And I think the most satisfying procedure is when we're doing gingival grafts or connective tissue grafts, because we get to see the results immediately. So it's basically when we have a lot of recession and we're trying to repair that recession, we see it immediately, the final results, once we sutured everything. So getting that satisfaction, seeing and showing it to the patient, like, this is how you're going to look in a few weeks once everything's healed, they're like, oh my God. So that reaction is what I like to see when I'm doing these types of patients and cases.
Thank you, Dr. Deliz. The next question is, how did you deal with failure or disappointment during dental school, and how did you pick yourself back up from that?
Yeah, I did have a few failures in dental school. Nobody's perfect. Basically, I just took a step back, saw what I did wrong, and made sure I didn't do it again, and got better prepared, and then went back in and did it again. I can tell you, I almost failed my perio class when I was in dental school. I had to take a remedial, and I prepared for it, passed it, and then look at me now, I'm a periodontist. So don't let failures keep you down. You just have to pass through them. Just figure out what actually happened, like self-reflect, see what you could do better, and then make a plan to get it done, and you'll get through it. I know boards also were a problem for me. I think that the second one I had to take twice, but it didn't stop me. You just gotta go in, see what you did wrong, and then prepare better and do it again, and then until you pass it. So it's just a question of being prepared.
Thank you so much for your great advice, Dr. Deliz. Another question we have is, how do you balance work and family life?
Well, family life currently involves a fiance and a four-legged pup. So there's no kids at the moment, so I get free reign what I do after work. So I do like to work out right after work. I either do it very early in the morning or right after work. So that's something I do. And, we try to get out as much as possible on the weekends. Usually the week is a little tough. But yeah, we like to just go out, explore, see new. The benefit of being in North Carolina is you got a lot of states surrounding you. So we like to travel. Everything is like 4 hours away, so it's nice on a weekend to just get out of town. Basically it. I used to love going to the beach. Can't do that in North Carolina as much because it's not the same as in Puerto Rico. But going to the beach, sleighing, getting some sun is usually my go-to.
Thank you, Dr. Deliz. And our final question for today is, what is one piece of advice that you would give a future dentist that you wish someone else had given you?
If you're trying to see what I would have said. Well, if you're planning, so I would figure out if you're planning on doing a residency, let's say, or not a residency, a specialty. I would figure out if you actually like it way before you say that you like it. Because I remember I was set on, like I said, I liked surgery, and the only thing I knew was oral surgery. They were the only surgeons. I had no idea about periodontics until I entered dental school. And unfortunately, I had a sight like, I'm going to be an oral surgeon. But then when I started getting more involved, I actually did not like it. So I wish somebody would have told me, or I would have had this option that you guys have, having these pre-dental meetings, to give me an idea of what is out there. Because I didn't know anything about periodontics until I was almost at the midway through dental school, or what they did. But this outlet gives you that opportunity. So my advice would be learn as much as possible out of all the specialties and what they do and what they can provide and help you with, so that if you are considering doing one of these, you actually have all the knowledge to see what you actually like, and go in it, go shadow, go see what these specialties are all about, and see what they can do in person, would be my advice, so that you know what you want and you don't get sidetracked as often.
Thank you, Dr. Deliz. So unfortunately, that is all the questions that we have today. We just want to say thank you so much for taking the time to be here with us and for answering all of our questions. It was a really great presentation, and we hope we can learn more from you in the future. So with that said, thank you to everyone who joined us today. The post-session quiz will be posted in our group meet. And thank you so much, Dr. Deliz, for your time again.
Thank you for having me, Sherry and Tiffany, and I hope to hear from you guys soon. And if you guys have any questions for me later on, you can easily send me a message through Instagram at Periodontic. I'd be happy to answer anybody's questions. You can easily follow my account. I usually post a few cases on there, and you can take a look and ask questions as well. So thanks again.
Thank you, Dr. Deliz. Be sure to follow Dr. Deliz at his account and reach out to him if you have any questions. Thank you again for joining our session today. We'll be posting our post-quiz in our group meet chat.
Thanks, everyone.
We hope you have a great day. Thank you.